Good morning, good evening, good afternoon, everybody. It is my great pleasure and honor to welcome you to this post-ASH 2024 webinar delivered to you by the International Academy for Clinical Hematology, the ICH, and it's going to be dedicated to the latest advances in lymphoma as presented in San Diego at this ASH 2024 Congress. This annual meeting remains a cornerstone of innovation and collaboration in hematology, and this year specifically has brought remarkable breakthroughs that promise to reshape the landscape of lymphoma care. Today, we are extremely privileged to have with us a distinguished expert in the field, namely Professor Ali Bazarbachi from the American University of Beirut Medical Center. The contributions of Dr. Bazarbachi to lymphoma research and clinical practice are widely recognized and deeply impactful. He is the current chairman of the Lymphoma Working Party of the EBMT, and he has kindly accepted to guide us through the most significant updates from ASH 2024, offering us his insights into how these findings could influence our approaches to diagnosis, treatment, but also, of course, how to improve patient outcome. As usual, this is being broadcasted live. I do encourage everyone to engage actively, so please feel free at the end to ask questions and share your perspective during the Q&A session. Thank you for joining us, and without further ado, I'm delighted to hand it over to Professor Bazarbachi. Ali, the floor is yours.
Thank you very much, Professor Moti, for the very kind invitation and introduction. Good morning, good afternoon, good evening, everybody. And I'm delighted to participate to this IACH webinar series on post-ASH to give you the updates on lymphoma from ASH 2024. Actually, there were a very large number, there was a very large number of very exciting abstract presentations in the last ASH meeting on lymphoma, different types of histologies. It's very difficult to select, so I tried to select the ones that I believed are the most innovative or impactful on daily practice. So I will be starting with follicular lymphoma with this abstract that was presented by Lori Sen during the late-breaking abstract on tafasitamab plus lenalidomide and rituximab for relapse refractory follicular lymphoma, the results from the phase 3 InMind study. So this InMind study is actually a double-blind, placebo-controlled, international multi-center randomized study that randomized the lenalidomide rituximab, which is becoming a very classical salvage therapy, or even sometimes frontline therapy in indolent lymphoma, particularly follicular lymphoma, versus the same regimen with the addition of tafasitamab, which is a CD19 targeted monoclonal antibodies. So we will have two monoclonal antibodies, TAFA anti-CD19 and rituximab anti-CD20. So the key inclusion criteria were adult patient with grade 1 to 3 follicular lymphoma or marginal zone lymphoma, at least one prior line of therapy, and no prior treatment with lenalidomide in combination with rituximab. And you will see that there was a stratification on early progressive, what we call the POD 24, those who progress within 2 years, the number of lines and refractoriness to prior anti-CD20 monoclonal antibody. So this is the primary endpoint, the PFS by investigator assessment. You will see a major increase of median PFS from 13.9 months to 22.4 months, hazard ratio of 0.43, highly significant. And when you look by subgroup analysis, you can see that the benefit from adding TAFA was in patient with POD24 or in patient without POD24, in patient previously refractory to anti-CD20, as well as in those who were not refractory to anti-CD20. And one very important endpoint, which is the time to next treatment. Actually, sometimes it's more relevant than PFS in indolent lymphoma, like follicular or marginal zone lymphoma. You can see that the median time to next treatment is not reached for tafalen rituximab versus 28.8. For len rituximab, the difference is quite big, and the hazard ratio is 0.45. So this phase 3 in-mind study met its primary endpoint of prolonging progression-free survival in relapse refractory follicular lymphoma with significant improvement in PFS and regardless of POD24 or refractoriness to anti-CD20. And what is interesting, as I mentioned, is to validate the approach of combining two antibodies, anti-CD19 and anti-CD20, for the treatment of follicular lymphoma. So it represents a potential new standard of care for patients with relapse refractory follicular lymphoma. Now moving to another Memorial Sloan Kettering by Lorenzo Falci, which is single agent mosunetuzumab, produces high complete response rates in patients with newly diagnosed follicular lymphoma. So this is the MYTHIC FL1 trial. This is the study design. Just to remind you that mosunetuzumab is a humanized IgG1-like bispecific antibodies, so targeting CD3 and CD20, that can be administered IV or sub-Q. And in this study, Mozu was used as sub-Q in frontline treatment for follicular lymphoma. So primary endpoint was CR rate per Lugano criteria, and inclusion criteria: adult patient with CD20 positive, previously untreated follicular lymphoma, grade 1 to 3, stage 2 to 4, and need of therapy per GELF criteria. So basically, this is the study design. You can see that patient received 8 cycles of sub-Q mosunetuzumab after initial step-up dose. And then you have response assessment. In case of complete remission, you stop there. And in case of a partial response, you continue up to 17 cycles total, and if no response, of study. So these are the inclusion criteria. 78 patients were included. You can see that 19% had grade 3A, 81% grade 1-2, 74% had stage 4, and these are the GELF criteria you used as indication for treatment: more than 3 lymph node area of more than 3 centimeters, or tumor mass of more than 7 centimeter, mass-related symptom or B symptom. Median age was 59, and patients were included up to 83. So this is the complete response rate. The overall response rate was 96%. For evaluable patient, 94% as intent to treat. Complete remission rate, 80%. This is quite high. And you can see on your right-hand side that the proportion of complete remission was extremely high, close to 80%, regardless of whether you had bulky disease, age below or above 60, baseline delta SUV, baseline SUV max less than 13 or more than 13, and grade 1, 2, as well as grade 3. And this is the waterfall plot. You can see how it looks. Almost every single patient had some degree of decrease from baseline in the tumor burden. And 86% of patients had at least 80% reduction in tumor burden versus baseline. So this is the progression-free survival. Of course, the follow-up is a little bit short for follicular lymphoma. However, to have 91% PFS without any chemotherapy, just with a bispecific antibody at 1 year, is already something quite interesting. The duration of CR, at least an estimated 90% of patients who achieved CR maintained their response at 1 year. And overall survival is still immature, but we had 99% overall survival at 1 year. And adverse events were quite modest. So no new safety signal, no ICANS-like toxicity, no tumor lysis syndrome, one episode of grade 2 tumor flare reaction. And you can see that we mostly had grade 1 or grade 2 side effects. Only in decreased neutrophil count, we had grade 3 or grade 4, but without significant infection. 2 words about the cytokine release syndrome, which is something that is quite common with bispecific antibodies. Here you can see that the incidence was 54%, however, 51% grade 1, 3% grade 2, so quite modest, and mostly encountered during the first cycle of treatment. You can see it will disappear in the subsequent cycles. So now moving to mantle cell lymphoma with the role of autotransplant as consolidation in the context of ibrutinib-containing first-line treatment in younger patients with mantle cell lymphoma. So this is, this is the triangle study, which is a European randomized trial with 3 arms. So far, the standard of care in mantle cell lymphoma was induction with chemoimmunotherapy, rituximab, for example, R-CHOP alternating with RDHAB, and then autotransplant, and then rituximab maintenance. That was the standard of care. And in the triangle study, we have 3 arms. The control arm, which is the classical one, R-CHOP, RDHAB, 3-cycle autotransplant. And then observation. So this is one of the drawbacks of this study, is that it started before rituximab maintenance was standard. So more than half of the patient did not receive rituximab maintenance. It was allowed. Then you will see a subgroup analysis on rituximab versus no rituximab. The experimental arm was A plus I, which is the same, but you add ibrutinib with R-CHOP during induction and 2 years of ibrutinib maintenance. And the third arm was without autotransplant, also experimental, and R-CHOP, RD-HAP, ibrutinib with R-CHOP, 2 year of ibrutinib maintenance. Again, rituximab maintenance was added following national guideline in all 3 arms. So A plus I was superior to A arm, which means autotransplant with ibrutinib is better than autotransplant alone, establishing ibrutinib as standard of care. And when we take all patients included in this study, the autotransplant arm was not superior. So this is a non-inferiority, was not superior to ibrutinib. And if any, we believe that the gray curve may be superior, at least in the first years, to the blue curve. So ibrutinib without transplant may be superior to transplant without ibrutinib. However, when we compare autotransplant with ibrutinib versus ibrutinib alone, you see no difference. So overall, the conclusion from this study was that maybe autotransplant can be omitted as consolidation in frontline treatment of mantle cell lymphoma when using ibrutinib during induction and maintenance. However, when we do a subgroup analysis, you can see that in blastoid variant, in high-risk patient with P53 expression, or a high-risk patient with Ki-67, more than 30%, the A plus I was superior to I, indicating that autotransplant is still beneficial for these subgroups. And I would like you to look for the lowest part of this forest plot. In the rituximab maintenance, it appears that autotransplant is beneficial when using rituximab maintenance. Autotransplant plus ibrutinib is superior to ibrutinib, and we will see that more later on. So this is for MIPI-adjusted hazard ratio. You can see that patient with low Ki-67, no difference between A plus I versus I, high Ki-67, significant benefit from autotransplant. The same for blastoid variant, significant benefit from autotransplant, and as well as in case of P53 high expression. However, this study only showed, when taking the overall population, only showed benefit in certain subtypes or high-risk features of mantle cell lymphoma, but not overall. Another abstract derived from this triangle study was presented by Marco Ladetto at the ASH meeting about the impact of rituximab maintenance added to ibrutinib-containing regimen with and without autotransplant in younger, previously untreated mantle cell lymphoma. So this is the study flow. You can see that some patients received rituximab and some patients did not receive rituximab in the 3-arm. On your left-hand side, the group A of autotransplant alone. In the middle, A plus I, autotransplant plus ibrutinib, and on your right-hand side, ibrutinib alone. So in every one of the 3-arm, you had around 1/3 of patients not started on rituximab and 60% to 2/3 started on rituximab maintenance. So this is the primary endpoint, progression-free survival. You can see that rituximab maintenance on your left-hand side with A plus I resulted in major increase in progression-free survival. So on your left-hand side, the 4-year PFS was 90% when using rituximab maintenance, 76% without rituximab maintenance at 4 years. And if you move to the right, for example, at 5 years, you can see that we are still having a plateau at 5 or 6 or even 7 years, which is around 85%. Whereas without rituximab, the drop is major, close to 50%. On your right-hand side, you have the arm I, which the ibrutinib without autotransplant. We still see a benefit from adding rituximab. So the blue curve is above the green curve. At 4 years, 85% versus 74%, which is good. However, in the ibrutinib arm without autotransplant, the PFS curve continue to go down and to drop to around 70% at 5 years, for example. So now, if you compare the blue curve with standard of care rituximab maintenance, on your right-hand side, ibrutinib without autotransplant, and on your left-hand side, ibrutinib plus autotransplant, you can see a major advantage of autotransplant when using autotransplant plus ibrutinib over ibrutinib alone when rituximab maintenance is used. So this is the comparative benefit from rituximab. You can see it across all 3 arms. And this is overall survival. P-value is not yet significant, but even in overall survival, rituximab is better than no rituximab. So finally, on mantle cell lymphoma, in the late-breaking abstract session, we had this study on lack of benefit of autotransplant in mantle cell lymphoma in first CR with undetectable MRD. So this is the initial report from the ECOG ACRIN EA4151 phase 3 randomized trial. So in this trial, basically patient with mantle cell lymphoma 18 to 70 in first remission were eligible. Any rituximab containing induction was allowed, and it explored whether autotransplant benefit patient achieving deep first remission as measured by an immunoglobulin high throughput sequencing MRD assay, the clonosec, 10-6 sensitivity. So this is the study design. They don't care about induction. So post-induction restaging, MRD negative CR are randomized between autotransplant with 3 years of rituximab versus rituximab alone. If MRD is positive or MRD positive CR or PR or indeterminate, you have autotransplant with rituximab. So this is the comparison for patients randomized, which means that they achieved MRD negativity with a median follow-up of 2.7 years. The futility boundary was an overall survival hazard ratio of 0.984. And basically, or randomized or treated as assigned, no difference and no benefit in autotransplant when MRD negativity was achieved. And this is the PFS, same results. And for arm C, basically the patient, the exploratory analysis of MRD plus patients showed the 3-year overall survival in patients who converted to undetectable MRD after autotransplant was 100% versus 63% for those who remained MRD positive. Basically, those who remained MRD positive after induction, if they convert with autotransplant to MRD negativity, you will have outstanding long-term results. So in this initial analysis, in the era of highly effective induction and maintenance regimen, mantle cell lymphoma patient in first CR with undetectable MRD 10-6 did not benefit from consolidative autotransplant, and patients who remain MRD positive after induction may benefit from autotransplant. MRD positive patient who converted to undetectable MRD 10-6 post-auto appeared to have improved overall survival and PFS. Of course, longer follow-up will be important to confirm these findings. So now moving to large B-cell lymphoma, where CAR T cells are becoming standard of care at many stages, initially in relapse after autotransplant or advanced disease, and now even in second-line treatment for early relapse or primary refractory. And here we have this CIBMTR real-world outcome of liso-cel in second-line large B-cell lymphoma patients. And some of these patients would not have been eligible to the TRANSFORM study that established liso-cel as standard second line for early relapse or primary refractory. And you can see here the response rate for overall response rate 84%, CR rate 70%, and similar results regardless of whether patients would have been eligible or not eligible to TRANSFORM study, and duration of response was excellent. Again, similar at 6 months duration of response, something between 70% for the not eligible and 78% for the TRANSFORM eligible patient, resulting in, again, outstanding PFS and overall survival at 6 months for these patients, with no difference between eligible and non-eligible patients. Another abstract on CAR T cell was the CIBMTR real-world outcomes of liso-cel in central nervous system lymphoma. So secondary CNS lymphoma. And we have very few data. We have data from EBMT, actually, that were presented at the last EBMT meeting, and here at the ASH meeting, CIBMTR data showing very interesting results with 73% of overall response rate, 64% CR rate in CNS lymphoma. This is not primary, but secondary CNS lymphoma. And duration of a response was 66% at 6 months, 42% at 12 months. So this is a high risk, poor risk population where a high rate of response can be achieved with liso-cel. But of course, we need to be able to maintain this response better. And this is PFS. You can see that patients who achieve complete remission have a significantly better PFS and overall survival as compared to all secondary CNS lymphoma. Sorry. Okay. So this is for safety. Of course, you would worry when you have CNS lymphoma about the potential complications, particularly ICANN, where they were they were not higher than usual, 16% grade 3, 2% only grade 4, and no grade 5 ICANN. And CRS were similar, 60% overall CRS, 42% ICANN. So safety is acceptable for this high-risk population. And then another abstract about the patterns of survival in large B-cell lymphoma post-CD19 CAR-T in second line versus later lines of treatment. So here you have second line, third line, or fourth line, and plus you can see that in this real-world analysis, you had 139 patients second line, 275 third line, and 285 fourth line or plus. Basically, second line and third line were a bit older, and the CAR-T product was mostly axi-cel in around 60% of patients, followed by Tisa-cel and liso-cel. And autotransplant prior to CAR-T was 6% in second line, 19% in third line, and 7% in fourth line or plus. And grade 3 CRS or ICANN were encountered in 6, 9, 11% for CRS, 15, 16, 17%. So quite similar for ICANN. And these are the comparative results to see if using CAR-T cell earlier results in better outcome than when you use them in more advanced disease. So overall response rate was quite similar, 71, 69, 67% between second line, third line, and fourth line or more. CR rate 60, 52, and 49%, slightly better in second line, but p-value was not significant. PFS was different overall, lower in fourth line or plus, but when you compare second line to third line, there was no difference in PFS. P-value was 0.7. And similarly, when you compare to fourth line or plus, the overall survival was better in second line or third line. But when you compare second line versus third line, there is no difference in overall survival. So median PFS was not better for second line versus third line, and median overall survival was not better for second line versus third line. And when you take patient with progressive disease, with the median PFS and overall survival from CAR-T infusion was, again, no difference, second versus third line. And fourth line is lower, even for patient with a progressive disease. So when you take overall, when you take with progression disease, when you take patient with double hit or triple hit lymphoma, then this is different. Then second line looks better, even if p-value is not significant, probably because of a small number, but the blue curve looks significantly better for double hit or triple hit. And in this abstract, when you look to multivariate analysis, you can see that two factors were important for PFS and overall survival. Using bridging therapy was associated with a higher risk or lower PFS and overall survival. And being in progressive disease was also associated with higher risk. However, the time of using CAR-T, second line versus third versus fourth line, when you adjust with everything, then there is no benefit from earlier use of CAR-T and no harm from using CAR-T in third line versus second line. So the key takeaway study messages from these studies is that outcome of CD19 CAR-T in the real world, despite a majority of trial ineligible patient, continues to demonstrate similar efficacy and toxicity rates compared with the pivotal trial. CD19 CAR-T cell therapy with liso-cel is safe for patients with a history of active secondary central nervous system lymphoma at the time of inclusion, whether this is in the history or active disease at time of infusion, but outcome of systemic and CNS lymphoma disease control were less favorable than for non-CNS large B-cell lymphoma historically. And attempts to compare large B-cell lymphoma patients treated in the real world in second and third line setting should be interpreted cautiously, as the data sets are, I mean, you have seen potential confounding factors and bias. And I would like to finish with this primary analysis of ZUMA-2 cohort 3 Brexu cell in patient with relapse refractory mantle cell lymphoma who are naive to BTK inhibitors. So these are the baseline characteristic: median age 64 and high risk feature 73%, high or intermediate MIPI score, 52% extranodal disease, and 47% high, 67 above 30%. And the overall response rate, 91%, and CR rate, 73%, and very few stable disease or progressive disease, and higher response rate across the different subgroups. So you can see here the PFS and overall survival, 75% for all patients, the 1-year PFS, 84% for those with CR, 65% for those with PR, and the 12 months PFS rate was 85% of patients still alive at data cutoff. And the 5-year update that was presented at the ASH meeting, ASH 2024. Of the ZUMA-5 trial in patient with relapse refractory indolent non-Hodgkin lymphoma, you know that Axi-cel is an autologous anti-CD19 CAR, and these are the 5-year update from the study. Actually, the ZUMA-5 study, after a median follow-up of 52 months, showed a median duration of response of 55 months and a median PFS of 57 months, median overall survival not reached. So this is a longer follow-up in follicular lymphoma and in marginal zone lymphoma, showing outstanding overall response rate, and the PFS and cumulative incidence of progression and lymphoma specific death. So median PFS was 62 months. The 60 months PFS rate was 50%. And among patients with follicular lymphoma, the 5-year rate of progression or lymphoma-specific death in this trial was 35%. And this is overall survival at 5 years. The rate of lymphoma-specific death at 5 years was only 15%, and median overall survival for all patients, follicular lymphoma, marginal zone lymphoma, not reached. And sorry, I was a bit long maybe, but I will finish with this study on behalf of the EBMT Lymphoma Working Party on autologous and allogeneic stem cell transplantation for major T-cell lymphoma entities by Evgeny Shumilov. So 2,578 autotransplant, 332 allotransplant registered between 2016 and 2022. So in the most recent era, and we took PTCL, NOS, angioimmunoblastic, and ALK negative anaplastic large cell lymphoma. So for starting with autotransplant, median age 57, and number of prior lines of treatment, 75% one line, and 83% of patients were transplanted in CR1, PR1. And these are the results. You can see that PTCL and OS, the PFS was 60% for CR1 patient, 42% with PR1, angioimmunoblastic 56.8% in CR1, ALK negative anaplastic 76.6% in CR1, and the results were better for the ALK negative than the two other histologies, but basically showing that results of autotransplant in CR1 are quite outstanding in the recent era. And this is overall survival. We are 75% for NOS, 79% for angioimmunoblastic, and 91% for ALK negative anaplastic. So at a time where we are waiting for the French randomized trial to see in a randomized manner the benefit from autotransplant in front line. In second line or more, for patients who achieve CR, we still have a very good results, 49% 2-year PFS, and overall survival 66%. Now moving to the allotransplant, the number of lines of prior lines of therapy was more than 3 lines in 46% of patients. 60% were in CR2 or beyond, and unrelated donor was used in 62% of patients. Again, when looking to the 2-year PFS, and second line CRPR, we're at 60% PFS, 66% overall survival. But interestingly, even in patient with stable disease or progressive disease, when using allotransplant in the major T-cell entities, you can achieve 40% 2-year PFS and 37.8% overall survival. So the conclusion from this study is that in major T-cell entities, the results of auto and allotransplant further improved, resulting in excellent long-term survival. And they differ by histology, better in ALK negative anaplastic than in angioimmunoblastic or NOS. Patient consolidated with autotransplant and CR1 achieve excellent PFS and overall survival. So autotransplant can be considered in not only in CR1, but also in relapsed refractory patient with chemosensitive disease. Outcomes after allotransplant are determined by disease status before transplant, not by the number of prior therapies, reflecting the equalizing properties of the graft versus lymphoma effect. Autotransplant work best in early CR patient, while allo should be strongly considered for all other patients. And this is for hepatosplenic T-cell lymphoma by Imke Karsten, again from the Lymphoma Working Party of EBMT. So this is 1 to 2% of T-cell lymphoma. It's a rare entity and generally a very aggressive behavior. And you can see here a 3-year overall survival of 55% and 3-year PFS of 50% with allotransplant. And in multivariate analysis, basically the disease status matters a lot, as well as the LDH level. So allotransplant is the treatment of choice for all eligible patients. Thank you for your attention.
Thank you very much, Ali. This is really a true tour de force, as we say, where you managed in 45 minutes or so to give us such a very broad perspective and insights from ASH 2024. And it's quite amazing because actually we're curing more and more patients. So we do have a lot of questions, so I'll try to structure them. So let's deal with this question immediately. So we have a question. Are we performing allotransplant in DLBCL after failure of CAR T cells? Is this something coming back, or allo is dead in DLBCL?
Well, allo is becoming less and less used in DLBCL, but it is not dead in DLBCL. And currently, after CAR T, we have 2 categories of patients that are becoming candidate to allo. As you mentioned, the patient who relapse after CAR T, and we had an important EBMT study published last year by Bertram Glass on this topic. But more and more, the response to CAR T is becoming the major determinant of predicting long-term outcome after CAR T. And patients who fail to achieve complete remission after CAR T are likely to relapse, and more groups are referring patients who fail to achieve CR, metabolic CR, PET negativity after CAR T for allotransplant, because their likelihood to have a sustained long-term remission is becoming very little. And this is a window of opportunity of consolidating or intensifying with an allotransplant.
Thank you. Very clear. And actually, in line with this question, we have another question from Dr. Dareen Mohammed, where she's asking about whether in refractory T-cell lymphoma, you would prefer auto or allo transplant, of course, assuming we have a donor and it is feasible.
And personally, I would say we almost never use auto transplant outside first line CR. This is a strong recommendation. Maybe in CR2, if not auto-transplanted in CR1, but even in that setting, it is allotransplant has shown an unbelievable graft versus lymphoma effect for peripheral T-cell lymphoma. And it will equalize, as we have seen, the number of prior lines. So allotransplant in frontline CR patient should not be performed. But outside frontline CR1 patients, in any setting, allotransplant should be done and try as much as possible to avoid procrastination trying to achieve CR in relapse refractory disease with 2-line, 3-line sometimes of treatment, and then the patient will not be transplanted at the end. So you can try for relapse patient 1 line, maximum 2 of salvage, and take your patient with CR patient, take your patient in PR, take your patient with stable disease, and if you cannot achieve a response after 2 lines of treatment, take even your patients with progressive disease to allo. This is different from acute leukemia, maybe, or other entities, but in peripheral T-cell lymphoma, it's quite powerful, the graft versus lymphoma effect.
Thank you very much. We have another question from Dr. Francesco Di Romendo about the InMind study, and he's asking whether there are specific subgroups who may benefit from this regimen. And I must confess, I was quite amazed actually with this combination of tafasitamab, lenalidomide, and rituximab. What are your thoughts?
So basically, from what was presented at the ASH meeting, everybody benefited from this, from adding TAFA. So patients who were refractory to rituximab benefited, and those who were not refractory to rituximab benefited. Patient with early progression, the POT24, and patient without early progression. So from what was presented in the subgroup presented, everybody benefited from adding TAFA to lenalidomide and rituximab.
Let's take one last question, and I know it's a more futuristic question because currently bispecific antibodies are not approved in second line, whereas CAR T cells are approved in second line. But assuming bispecific are coming into earlier in the course of the disease, how do you see the competition, I would say, or the positioning of bispecific versus CAR T cells? I know in multiple myeloma, this is probably one of the hottest topics. And of course, bispecifics are off the shelf, easily available. CAR T cells, you need to wait a bit. So what can we say about this? We have a question about this issue.
So let's take 2 lymphomas, follicular lymphoma and diffuse large cell lymphoma. So in follicular lymphoma, I presented this ASH abstract, this ASH 2024 abstract of using a bispecific antibody in frontline treatment. So the safety of bispecific is, I think everybody would agree, superior to that of CAR T cells. And when you use a bispecific off the shelf, sub-Q, in frontline treatment of follicular lymphoma without anything else, and you see this outstanding response rate, we have to wait for the duration of response. So I think that logistically speaking, practically speaking, it will be very difficult for CAR T to compete as frontline treatment in follicular lymphoma when you have a product that you can give in the clinic, I mean, sub-Q. So now moving to large B-cell lymphoma, we have ongoing, I mean, for the sake of time, I did not present this abstract. Maybe I should have presented it using R-CHOP, removing vincristine, adding glofitamab and polatuzumab. And basically, you are curing more than 90 to 95% of patients frontline with adding two monoclonals, polatuzumab and rituximab, like the POLARIX trial, and adding to the POLARIX glofitamab bispecific antibody. So again, if we have long-term follow-up and then a randomized trial, then I believe that this will establish bispecific. I mean, treatment of particularly frontline treatment, Muhammad, of follicular or large B-cell lymphoma is not necessarily done in the biggest university hospital academic centers with availability of CAR T cells. The bispecific can become available in proximity treatment centers in small towns, in everywhere, without the needed logistics for producing CAR T cells. So I don't know if I answered the question, but I believe that an off-the-shelf product that can be given sub-Q immediately, it will be difficult for CAR T to compete with that.
No, I think you answered very nicely, and I think your perspective quite clear. One last quick question, because we didn't discuss this in the webinar, the EBV PTLD and the role of cytotoxic lymphocytes. I know it's a very rare orphan indication. Any thoughts on this? Because we have a question in which situation you would use, especially that I think they are commercially available now. There is an approved product, EBValo, and any thoughts on this?
So if you have the product, you can use it. I think that the answer is as straightforward as that. So I think that PTLDs are not all equal. The EBV PTLD, you have the early polyclonals, sometimes easy to address with just rituximab. And then the one that are more monoclonal, more nasty lymphoma-like PTLD, and I think that for those, if you have the product, use it. We used to give our CHOP for these patients.
Wonderful. Thank you very much, Ali, as we conclude this fantastic webinar on the remarkable advances in lymphoma presented at the last ASH 2024 Congress in San Diego. I would like to extend my deepest gratitude to all of you for your active participation. I apologize if we didn't take all the questions, but we are reaching the end of the webinar. A special thanks to you, Professor Bazarbachi. Your expertise and clear vision has shed some light on the transformative innovations shaping the field of lymphoma. And I really like your ability to distill the latest finding and their clinical implications in a very nice way. I think the progress we've discussed today is a testament to the power of collaboration, dedication, and relentless pursuit of better outcomes to our patients. So I would say let's all together carry this momentum forward and continue to push the boundaries and translate these advances into real-world impact. So thank you all once again, and we look forward to welcoming you to future events by the ICH around the globe and across the hematology field. Together, we're making a big difference. Thank you very much. Take care.
Thank you. Bye-bye.